Yeah, well, if we're saying that the spasticity is not fitting any of those three categories, but it's getting worse and worse, and we know that hand is going from here to here to here to here, we know that it's going to go into their palm. We know there's a rapid progression that we need to start treating it one way. So look at that case. I just want to make sure that we're remembering our rehab issues. What are our rehab issues? How are we framing things? Just tell me quickly. Bowel, yes. Bladder, what else? Skin, what else? Gait and ADL's function, great. Sleep, good, what else? Psych. Cognition, yes. Okay. Did we talk about emotions? Cog, psych, nutrition, pain, spasticity, bowel, bladder, ADL's gait. Okay. Just remember framing it that way. Just hammer that home because your auditions are going to come soon. So if you're organized, you're going to look absolutely fantastic. So look at that, and just go. It's easiest. Let me just tell you. The ones that I want you to look at is look at current functional status. Look at pain. Look at energy. Look at medications. Look at sleep, spasticity, bowel, and bladder. And then tell me, what do you want to do in terms of treating this patient? Do you want to actually intervene, or do you want to leave it alone? I think I made it pretty dramatic for this guy. So. All right, so what do you guys think? So we've got spasticity, the diagnosis for this person. Remember, think about the person, right? Think about if you were in that person's shoes, how this stuff impacts day-to-day life. So let's just go bottom up. So bladder-wise, you want to read the bladder one? The spasticity-wise, what are you noticing? How's the bladder program first and foremost? It's decent, right? He's got a spinal cord injury, which means what kind of bladder dysfunction will exist? Sorry? Overflow. Not necessarily overflow in theory, but is it, what's up? It's a neurogenic bladder, all-encompassing term. Just if you say just to kind of clarify, right? If we say neurogenic bladder, that just means there's a neurolytic dysfunction in the bladder, but that could be any nebulous thing. So, but you're correct. The bladder, are you going to be retaining, or is it going to be just coming out all the time? You should be retaining, and it's because it's below the pons. It's going to be detrusor sphincter dyssynergy, but you're going to retain. And so if you retain, what's the way to get the urine out? Cathode, fantastic. And in this case, I think he's cathing how many times? 4 times. His voids are where? 300 to 500, so that's right on point. That is so he's doing great. Is he doing his fluid restriction or fluid management program? He said he did, 1.6. So he's doing everything in his power to do a good job. Is that fair? Now, despite this, what is he noticing? Yeah. It might be stress incontinence. You could go further, but if you've got a bad cord injury, you've got bad spasticity, what muscle could also be spastic? The detrusor muscle could also be spastic. So in this instance, spasticity, he's doing everything he's supposed to do, but he's still so spastic every time he moves or turns, that muscle's just kind of, so it's the same thing. If you hit your reflexes for this guy, what it's going to be? It's hyperreflexic, right? He's going to have clonus. It's almost the same thing's happening here. So in this instance, what do you want to do for that? I mean, does your field have the specialty to deal with this, first and foremost? You can be honest and say no.
Is it too aggressive to consider a baclofen pump?
I think it would be a little too aggressive just for that.
Yeah. Because
what are our options? Let's go over our options here. We could do nothing if we wanted to. We could splint. I think it would be difficult to splint, the bladder. I'm not being super sarcastic, but yeah, right. The splinting is not an option for this. We have oral medications. Okay, is oral medications potentially a solution? It could be.
Something like atropine or
atropine might be too aggressive because remember our spasticity options are baclofen, Valium, tizanidine. Those are and dantrolene are your big 4. Or we can do, we said pump is an option, I think might be a little too drastic. Botox? Botox? Yeah. Now, I'm not going to do that
Okay.
because you need a urologist to do it. So in this instance, you can say consult. From your perspective, you've exhausted all of your conservative measures. Oral medications, remember, go everywhere. So you can consult urology, and they can scope, and then they can just inject Botox right into that detrusor muscle. We're good. What they would do before is a urodynamic study. And what they can actually figure out is, we're saying 300 to 500, okay? The urologist might do a urodynamic study and saying, they actually start spasming at the 450 mark. So maybe adjusting that fluid management program and the catheter program so he's at the 400 mark and then you're sitting pretty. The guy might say, that's just too crazy, I'm going to be restricting my fluids too much. Why don't we just do Botox every 3 months and then see what happens? Or he might say, I restricted to 400, but every once in a while I'm still kind of spasming to do the Botox. So, okay, so we have a conservative measure, because if we went crazy with just the baclofen orally, what is a big side effect for this person that you don't want to see? Is that? Sedation. Isn't he already complaining of sedation? Yeah. And you're not really going to get an outcome that's going to solve the problem as much as that Botox did detrusor. Bowel-wise, was there any issue? I forget. No? Okay. And then we spasticity, obviously that's the whole thing here. What about sleep?
That's an issue.
So it's definitely worsens at night, waking up.
Sure. How do you feel about that? I mean, what I'm saying is that we're talking about from the context of spasticity. Do you feel like, how many people here would say, let me just try to address the spasticity, or do you feel like, even if you address the spasticity, he's still not going to sleep? Which way do you think?
Well, there seems to be an element of anxiety.
Yeah.
And I guess you don't really know how much of that is like due to spasticity.
Yeah.
Or so maybe like address the spasticity, and then if there's still something going on, then you look at the anxiety.
Yeah. Yeah, no, then that's the point, right?
Yeah.
I don't know. I mean, I made a fake patient, but that's kind of what happens. So you can do one of two things. One, you can say, you got a lot of problems at night. Like, that's a whole another separate issue. You could say, maybe we can try to fix the spasticity and see what happens. But then with both people mutually understanding that, look, you might still not be sleeping because of insomnia and because of your anxiety and blah, 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 blah. Now, let's say that I'm like, okay, we don't have this bladder issue, but I want to give a medication at night that might help control spasticity and help with anxiety. What could you pick? Of the 4 choices we had.
Valium was one you mentioned, right?
Yeah. So Valium would be actually a pretty good choice. So you have baclofen, tizanidine, dantrolene, and Valium. Now, don't start up with Valium because it's a benzo-controlled substance. There's a huge kind of issue with it. But if someone's got a max out on baclofen, you need to use another one, especially in spinal cords. Valium gets used often. Now, where I would cringe, I'll be honest with you, when Valium is used for spasticity, I think people are very open with it. When it's used for anxiety, people are like, well, that person might have a higher risk for addictive properties. You need to kind of go in a different way. So use a creative thought. So when you go on your rotations, don't just throw in Valium right off the bat. But you could if you wanted to. But in this patient, I would say there's too many things going on. I'm like, let's get you to a psychologist. Let's focus on getting that anxiety better before we start dually treating both. Okay? Go ahead.
What's the max dose of baclofen for like higher doses?
Yeah, so it's 10 4 times a day, right?
Mm-hmm.
So the manufacturer's label will say 20 4 times a day, but practically you can go up to 40 4 times a day.
Okay.
So you can do, the manufacturer's label will say 80 4 times a day, but you can go up to 160 4 times a day. The manufacturer's label will say 80 split into 4 doses, which is 24 times a day. Yeah, and then or 160. So you'll see it written both ways.
Yeah.
Okay. So we got that done. What about his? We talked about sleep, the bladder function. What about gaze? What do you want to do with that?
Would PT be helpful? Because he's crossing over and he's stumbling when he gets tired.
Yeah.
So that's
Germany, crossing over. What does that? What does that mean?
like I think it's when it's walking and it's like his right leg is crossing over his left.
Yeah.
Instead of staying parallel.
Yeah, absolutely. There's a couple of things. You'll see it very dramatically. So there's some people that have really tight adductors. They'll actually walk, just pretend I'm holding out as a walker. They'll just like kind of cross over and they'll cross over. This is like super aggressive here. But more subtly, what they'll actually end up doing is, instead of us having, see this, the two lines here? Like you're kind of walking here, okay? What they'll end up doing is just get a very narrow base of gait. So they're just walking and they're just walking. It's not even like overcrossing, but they're just kind of what they call a scissoring gait. And what can happen is if you're scissoring here and then someone calls you, you can't clear that leg as well as you can, and you can stumble and fall. So if the problem is it's the adductor muscles, right? So let's say that everything else with spasticity is okay. The only problem is adductors. What could you do for just the adductor muscles if they're just one problem child muscle? Injection. What do you inject? Botox, absolutely. So if they're saying,
Is there like a worry of like having more weakness and then having difficulty walking? Would you go straight to Botox?
well, the question one, weakness is always something people bring up. Every time. Like half the people will be like, oh no, don't do it, they're gonna get weak. I'm more of the mindset of, well, you're gonna start off with conservative measures. Have they stretch? So to answer your question, I think the first thing we would do is, in therapy, give them their stretching protocol for the adductors. A lot of people respond really well because they've neglected this. Then you can try your orals. And if both of them don't work, then you have to tell the person very honestly, we can try the Botox. It might get it weaker, but we should try it once and see what happens. The other thing is that if you do Botox to the quad, that's where I get worried, because remember, the quad is like really holding you up. The adductors are not holding you up. They're either preventing you from scissoring or not. So I never touch the quads. When I do Botox, I'll do the hip flexors if I need it. If someone's like not able to bring their leg backwards, then I'll do the adductors. And then like gastrocs and stuff like that. So it's not, the weakness part is not as big of a, yeah. You're not gonna take someone who's ambulatory to being non-ambulatory because of that. So we can do that. And then the descriptions. I always like this description. If you're ever in clinic and someone's got old cord injury and they've got subtle spasticity, you can ask them, does it feel that you're in water that's about waist deep, that you're walking and there's just this resistance but the rest of your body's not following suit? People usually respond to that. They're like, yeah, there is some stiffness. So in this person, you want to treat the adductors. What else did you want to do? Do you want to treat anything else or no? That was kind of problematic spasticity to us?
I mean,
Yeah.
just combat the like over adduction, we also like strengthen adductors to that and try to like hold like on.
Yeah, oh, absolutely, absolutely. And that'll be part of that therapy protocol, right? You might be doing some clamshells, you might be doing some glute isos, and as you're doing them, like if you're doing your side lying externally rotated and lifting your leg up, you're gonna have to stretch your adductors. The key is gonna be counseling that person properly. Because when people do their therapy, they're always gonna try to cheat. So they might cheat and like not get the glutes and then keep the adductors tight. So was there something else? I think you had mentioned the fatigue. What about that?
I don't know if I mentioned the fatigue actually, but was he saying he's getting tired throughout the day and he says the mechanics are breaking down as he goes on. So that's might be either mechanical thing where he needs to build up the strength in those muscles that are weak, as we've talked about. There could be a portion of his anxiety that's playing into that as well.
Sure.
He might have a mental barrier too.
Sure.
Some degree of.
And when you were, and this is a general question, the word fatigue got thrown out. I mean, it's written on there, not you made it out. What is that? What are the two main kind of descriptors of fatigue? Because if someone told me they were fatigued and they're on that list of meds, what is my first inclination to blame?
Norco.
Yeah. Well, yeah, the meds, right? I think there's a lot of validity. Like all these meds are not good for you. So, but what are the two kinds of fatigues that you need to be mindful of?
It's like
What's that?
like more of like a cognitive or energy level.
Yeah,
versus
there's
like
a
physical.
Exactly. There's this thing called, it's like central fatigue, which is kind of like energy, and versus like muscle fatigue. And so for this person, where you're kind of like shooting off a lot of these different meds, you got to ask that question: is it a physical fatigue, or is it the darn meds from the that central fatigue? If it's central fatigue, we have to really look at the medications. But if that person said, no, the meds are fine, I'm doing great, I just work my ass off, and then by 5 o'clock, I'm so physically tired that my mechanics break down. So in this instance, if he were to say, I feel good energy, I mean, he doesn't say that, but the person had good energy, you would say, okay, we'll keep the meds the same, we'll just do more energy conservation. Person's like, I feel like crap, then I need to say, all right, get rid of the Norcos first, maybe switch the baclofen to something else. So that's only kind of comment I wanted you to make, so ask that question when you see him. Is there anything else? I mean, do you want to go up on the baclofen, go down to the baclofen?
Not necessarily the baclofen, but I don't really think the Elavil is doing anything for him.
Yeah.
And for his sleep, I
Yeah.
mean, it seems like he doesn't have a problem getting to sleep. It's
Yeah.
more so staying asleep
Yeah.
and getting interrupted. So typically Elavil is more so for like sleep onset.
Yeah.
So, and also it's probably making you more fatigued.
Yeah.
And he's already on Prozac as well.
Yeah.
So I think you can probably titrate the Prozac because there's definitely a component of anxiety. So I think maybe getting rid of the Elavil might give him more energy, and then titrating his Prozac and maybe the spasticity stuff
Yeah.
will help him much more.
Yeah.
And make him feel better. Probably.
Absolutely. That's a fantastic way to think about it, right? So, no, I agree. The question you need to ask yourself, why the hell are you on these meds? Like, what are they doing for you? And that's the answer to the baclofen question. You should ask me, like, if you're going to say I want to go up on the baclofen, my question will be, what do you want to do? Why? Because I'd much rather go procedural, or like, if we're doing the 80 doctors, I'm going to get my bang for my buck there, right? If I do the Botox. So, getting slash and burn. I think the one thing for you guys to know when you go on these different rotations is when you see a patient with a lot of meds and the doctor with is adjusting all those meds, just be very thoughtful and respectful, because everyone gets super defensive, like, yeah, I can prescribe these oxys, man, what do you tell me about? But you can just be like, you know, if they're asking you a question like, hey, what would you do? You know, go to the like consolidating and like decreasing the meds, because the big thing that's coming out is less opiates. You guys all heard that. You guys getting educated on it too. So yeah, that's amazing. That was a good answer. So, anything else? Anybody? Any other thoughts? Concerns? Okay. And then you guys remember our MAS score? What was 1 through 4? What is 4?
No.
What's up?
No.
No movement. It's contracted. Okay. What are the two ones that you should remember? Is 1 plus and 2. What was the difference between 1 plus and 2? It's not boring, but just say it out loud. Somebody read it. 1 plus is you're doing your range of motion, and there's a spasticity that exists for less than 50% of the range of motion, and then 2 is greater than 50% of the rotation, but the range of motion is fully intact. So once it gets to 3, it's kind of getting stuck, and then 4 is stuck. And if you have someone who's at 4, and I'm shooting Botox in there, what question should you? I mean, you should feel comfortable asking me any question, but what question should you ask me? Like, yeah, I'm gonna Botox his bicep stuck. What's that? That's a question I would ask you if you're gonna Botox that.
How much Botox are you going to use?
Nah. Let her rip. Do whatever.
How much improvement do you expect to get on it?
Good, fantastic, right? What is your intent there? Because one, I've got to, for the most part, be able to say it fits into any of the categories we talked about, either a caregiver's ability to improve hygiene, one's own function, pain, or rapidly progressing. And then if I were to say, well, it's a 4, so technically, would I know if it's going to move? It could be contracted, correct? And so if I want to distinguish if something's actually contracted or has some element of potential, what's that procedure I can have someone do for me to check the range of motion?
Nerve potential?
I'm sorry?
Nerve potential?
No, nerve something.
Stimulation?
Nerve conduction.
Nerve conduction would be EMG. That's to see the health of the nerves.
Yeah, nerve block.
Yes, a nerve block. So you completely paralyze the arm for, 2-3 hours, then you can see how much is floppy. Whatever's floppy is the potential. So I would have to respond back to saying, like, I know it looks like a 3-4. I did the nerve block. I actually have pretty decent range of motion potential, so I'm going to let it rip with my Botox. You know. And so always ask that question, what am I trying to get out of it? That's how you get patients to really believe in you, where you can say, this is what I can actually offer you that's going to make a difference. So the goal question. Cool. Any other questions? Good? Okay. Neuroanatomy, boring, right? So I'll be real. Super boring. Why do we hate neuroanatomy? Boring, and you have to memorize it, right? And then I don't remember that crap. So I'm going to try to figure out a way that we can remember this stuff super easy, because on your neural brain rotations, if you know aphasias, and I'll try my best to help you remember it in a very, hopefully, easier way, then you'll look really smart, because I guarantee your PGY2s do not know about the aphasias because they were just memorizing stuff, okay? So remember, stop memorizing and let's get through this. Different areas of the brain, what do we got? Give me 4 areas of the brain. Frontal and occipital. Temporal. That's all you need to know, right? Big areas of the brain. It's just like different countries, and different countries have certain characteristics, right? I'll only comment about India, so I don't get myself in trouble because we're recording now, right? PC now. I'm just kidding. I won't say anything. But different areas of the brain have a jurisdiction, okay? Unlike you guys, sorry. The brain works together, but everyone's got a job, right? They're all good teammates here. One of the main things I want you to know is, remember with the brain, they have these 2 big strips, the motor strip and the sensory strip. What does the motor strip do? Motor. What does sensory do? Okay. So first thing, when you guys look on the board, what part of the brain has the motor strip? Frontal part, okay? And what has the sensory part? Parietal part. See in the homunculus, there was a stroke, the MCA stroke that's like, boom, right here. What is affected from a motor perspective if it's right here? Face and arm. And is the leg going to be affected potentially? A little bit, but it's going to be less, right? And same thing with sensation. If I said you had an ACA, which is more on the inner part, like as it curves in, what's going to be more affected? Lower extremity. And then less of the arms and well. But be mindful as you see these people is, remember, there's a lot of swelling. So when swelling happens, everything gets affected. The lobes of the brain. Okay, we got to think of 1 to 2 words for each of the different lobes of the brain so you remember it. Okay, let's do the easy one. I don't know why I remember this, but what occipital lobe? What's a verbiage for that? What's up? Vision. Boom. Just vision. Let's not even sweat that, right? Okay. Then the rest of them, it's kind of a wash, right? Frontal. What's one word?
Personality.
I like personality. Only because I wrote personality on the slide, so we'll take that. Personality, but personality plays into.
I said decisions.
Yeah, decisions,
okay.
Right? Like we all have friends, make some wild decisions, and you're like, yeah, he or she. They're just like that, right? That's their personality. But what allows you to be successful in med school is a lot of it's your frontal lobe. What allows you to be? How do you get to med school with your frontal lobe?
Higher thinking, decision.
Good decision.
Process.
Yeah, honestly, because and when you think about like the actual intelligence part, it's a different part of the brain. But what if you have 2 smart people, one is successful in med school and one is not, you guys are here. It's like the motivation, right? The hard work, the good decision making, all that kind of stuff. That's independent of intelligence. So just think of the front part of the brain as being like what's made you successful in med school. If you took that away, it doesn't matter how smart you are. Maybe you won't be successful. I don't know. What about parietal and temporal?
Temporal's like memory.
What's that?
Memory for temporal.
Yeah.
And then space for parietal.
Yeah.
Spatial awareness.
Yeah, it's great. Nice. That was good. Awesome.
Thank you.
It took me forever to figure it out. So you've accomplished it in 2 seconds. I racked my brain all week. I was like, I got to think of good words. And we'll get to it in a second. So temporal is right here. The only thing with temporal that we're going to add on, I have a bigger slide, is temporal is like close to the ear. So what else does it add on to? Hearing. Yeah, it's got all the auditory stuff. And the parietal is a little bit higher, and it's got all the more the visual stuff. But we'll talk in a second. So frontal lobe here, okay? So with frontal lobe, boom, smack dab in the middle, all the things that make you successful in med school. So it's got basically its personality. So keywords, boom, personality. You can see, I put the keywords there. So if you've lost your frontal lobe, that's where the people get wild, they get crazy, they start punching people out. They're planning, they're sequencing, they're motivated, initiation. So if you've got, there's a lot of dopamine here. Remember our dopamine medication? What is our dopamine medication we throw at every brain injury patient, basically, nowadays? Amantadine, right? So we've lost of dopamine, which means in the rehab unit, they've lost some elements of their frontal lobe kind of thing with motivation, initiation, task persistence. Do you need all that in med school? Yes, so just take a bunch of amantadine, you guys will be successful. Parietal lobe, okay? So this is where it gets a little tricky. So the keywords are localizing and processing sensory information. Mainly meaning understanding the environment, okay? So proprioception is what? Describe to me what you think proprioception means to you.
Where you feel your body is in space.
Yeah, feel your body is in space. It's not really understanding it, but what I see, I see this chair here. For me, obviously without having parietal lobe injury, I see it and I go around here. If I'm perceiving this environment incorrectly, I'm going to say, oh, I see the chair. I'm going to move my foot, and boom, I smack it into it, right? And so it's a lot of visual spatial stuff. So it's a sensory information from a visual perspective. It's also localizing stuff. So it's like visual focus. So if I were to say like, hey, where's the door? You'd be able to say it's 10 meters that way if it was like a military guy. Well, you're gonna know that in a second, right? Mr. Navy? Yes? Yeah. So you can be like, it's 10 meters that way, ba 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 ba. If you lose your parietal lobe, you're not gonna be successful in your military career, right? So right-left discrimination, acknowledgement of the environment. So this is where when people have neglect, this is where they lose it. And then there's some motor planning stuff. So it's visual spatial and it's proprioception, how you're interpreting that environment. That's all parietal lobe. Nothing to do with memory and like processing that information, processing it from like an interpretation. There's more of gathering that sensory information. And so if I have if I'm given bad information and I'm taking a test, am I going to do well on it? If I study for a math test for an English test, am I going to do well on it? No. No matter how smart I am, I'm going to fail that English test. So this basically tells you what test to study for. This gives you the intelligence to remember it and execute it. Does that make sense? Everybody? Cool? Okay. And the main thing is, have I talked about language here? No. We're going to talk about language in a second. So this is independent of language. This is independent of motor and sensory. Okay? Because we know motor and sensory are located where? Where's the motor strip? Frontal lobe. And the sensory slip? Parietal lobe. So it's actually, boom, right here. And what's that thing that divides it? Central sulcus. Okay? So if I had, so this is, tells you what to study for. This helps you remember it, right? So temporal lobe, if the parietal lobe up here is all about vision, temporal lobe that's closer to the ear is all about ears. What's the main thing the temporal lobe is known for? Memory, right? You just got to remember all that crap. But also gets you, when the parietal lobe gives you that information, it actually puts it together and spits out information. So if you're trying to identify an object, the parietal lobe says, it feels like these 10 little objects, which ends up being like it's a piece of paper. And you're like, oh yes, it's a piece of paper. It actually process that information helps you identify that object. But if you're thinking of two main things, the words are, it's like organizing and interpreting that information and the cognition and memory. So if you've lost your temporal lobe, if you're drinking the sauce too much, if you have some sort of temporal lobe injury, then you're going to lose your memory. Okay? So we said easy, occipital lobe, everybody knows this, is locating objects in your environment. So this is just the actual visual part, the mechanics of seeing something. So what ends up happening is that the occipital lobe sees, shoots up to the parietal lobe that says, oh, I'm seeing, collecting all this information from a visual spatial perspective, and I'm shooting it out to the temporal lobe that then interprets it and says, and then tells you the frontal lobe, do not hit this person, right? That person is flipping you off, right? Does that make sense? The whole like, we won't go more into that. But the other thing is that occipital lobe, if you've got damage, what could happen? Hallucination. So if you've got a seizure of your occipital lobe, what could that person complain of? Not shaking. What could they say? Yeah. They can have visual hallucinations that end up being these subclinical seizures. So if you've got someone that had an old occipital lobe injury and they're hallucinating, what could be in your differential? So that old occipital lobe stroke, and they're coming in saying like, hey, I'm just saying things. What's in your differential?
Drugs.
Yeah. Okay. Let's do a good differential here, right? So it could be drugs. Okay. What else?
Dementia.
Could be dementia. So it could just be pure cog, right? What else?
Well, wouldn't like Lewy body also have hallucinations?
Yeah. And so we can just say it's a brain injury of some sort that we don't know about. Okay. It's a new injury. What else?
Psychosis.
Yeah, psychosis. And that could be it could be drugs. It could be the fact that it could be, drugs as in like illicit drugs or medications that got given, or they could just be developing psychosis just from a delirium of some sort. stuck. They're stuck in 4 walls forever. What else?
Be epilepsy.
What's that?
Be epilepsy.
Yeah, it could be the subclinical seizures. Okay. And so if we're saying people that we would consult here would be neuro. We definitely consult psych. Who else would be consultants here? This is neuro. I'm not saying that we need to consult them. It's like how we're organizing it. So what other consultants could give us insight? Anybody else? Would ortho have any insight into it? Not to say that ortho is bad, but not really, right? Would vascular have any? No. What about ID/rheumatology? I have a maybe. Just give me a maybe. Throw me out a maybe.
Yeah. Do you think it's like CNS lupus or something?
Yeah. All right. Good. I like that. Right. Some sort of infection.
Toxoplasmosis.
Yeah. Yeah. Just go down the whole infection. Just do like some sort of meningitis. It could be.
Yeah. Would you need onc in that same vein if there's a tumor?
Yeah. Absolutely. Absolutely. Throw in an onc process. What I'm really trying to get is you organize your differential. Just think of all the potential rotations or consultants, and then saying what would they potentially say. Organize yourself with the most obvious. I'm totally joking, but you wouldn't start off as that. You're like your top differential there. You would just say the obvious. I mean, like someone came in through the ED, you'd say, I would say drugs and alcohol like off the bat. But in that person, what is often missed is the fact that they could be having subclinical seizures. Because they could have, a urinary tract infection that's causing that psychosis. I have a patient in the hospital now, UTI, and unfortunately, psychosis. Okay. Cerebellum, what does that do? Coordination. Okay. So the easiest ones people always remember is the cerebellum and occipital lobe. Frontal lobe probably second, and then parietal and temporal lobe. If you can just remember parietal, temporal lobe, you're going to be good. So let's go into the aphasias here. I want you to remember only 2 things. And then we're going to use what we learned about the motor and sensory strip. So motor strip is where located? Frontal lobe, and then the sensory part is where? Parietal lobe. So, and you can see it here. So this would be, your frontal lobe, and there's your motor strip. This would be your sensory strip. You guys remember Broca's? Okay. Broca's aphasia. Where's the Broca's aphasia? Is it closer to the motor strip here? Is that fair? So if I'm trying to voice and produce words with Broca's aphasia, what's going to be the problem? Yeah, you cannot spit out any words, right? It's just going to be garbled. That kind of would be that a Broca's aphasia. So what I want you to think about, Broca's is in the frontal lobe, so you're going to think motor. So with motor, you're not. There's another slide for this. So you're not going to be able to spit out the words. Wernicke's is more in the temporal lobe, and the temporal lobe we talked about with you're getting all the information and then you're putting it all together. So what's actually off with Wernicke's? Comprehension. Yeah. So just the comprehension part. So when you learn of aphasias on your rotations, I guarantee you a PGY2, a PGY3, God bless them, I've been that one time. They're going to read the Cucurilla book, which is the board review book. Okay? It's absolutely fantastic. So they're going to ask you, they're going to break it down into a couple of things. They're going to say repetition. They're going to say comprehension. Wow. And what's that? Fluency. Yes, you are on it today. Fluency. Okay. So if you've got a Broca's aphasia, which means that you have a frontal lobe injury, the motor part is gone, you cannot get words out. Is fluency intact?
No.
No, you have no fluency. Okay. What about who's in charge of comprehension here? What? Yeah, temporal lobe, and we're going to say Wernicke's, right? Wernicke's area. It's actually called Wernicke's area, it's Broca's area. So Wernicke's involved with comprehension. With a Broca's injury to the Broca area, is Wernicke doing okay? Mm-hmm. Absolutely. So is comprehension going to be intact with Broca's aphasia? Yes. Okay, good. And what about repetition? Who's in charge of repetition?
The pole strip.
So everyone's, yeah. I heard words. Yes, fasciculus. So going back to this, just to review, we said Broca's is going to be closer to the motor area, and it means that you can produce the words, so which means that fluency intact or not intact?
For Broca's?
Yeah.
Not intact.
Not intact. Comprehension?
Intact.
It's intact. And repetition?
Impaired.
Not intact, right? And then with Wernicke's, Wernicke's involved because it's close to the temporal lobe, is just interpreting all that information. Okay, are you going to have comprehension? No. Is Wernicke or is Broca's still open for business, and do you only have fluency? Yes. And is repetition intact? No. And repetition is not intact because our whole track is messed up. Great. Easy money here. You all remember this? Yourselves real quick. The Cucurullo book. So let's do these all randomly here. Who wants to do the first one? Just come up and write the answer for one of them. Do the easy one. Do the global aphasia, somebody. Yes. Yes. Oh, yeah. So what you're supposed to do, what you're supposed to do is pick it from fluent, just go down whichever way you want to go down. So, you see what I'm saying? Okay.
Kind of. So, globals are just going to be negative. I don't know. They're all negative, whatever it is.
Yeah. And so remember, this is actually here. Let me put this here for you. This would actually be a negative, and this would be a positive here. So you want the all negative one, right? So which is the all negative one? This one right here, right?
Yes.
So this one is global.
Okay.
Yeah. Perfect.
Kind of understand this.
It's all right. It takes a little bit of time. Don't worry about it. This is your first time going through.
No, I just don't understand this grading
Oh,
system.
yeah. And all you're really doing is what I would do is look at it here, because this is going to be harder to remember. So remember, if you're going to do Broca's, okay, let's do Broca's, right?
See.
Yeah. So is it fluency?
Comprehension. is intact.
Yeah, comprehension's intact. Okay.
Okay, so fluency.
Fluency is there. Okay.
So that's negative.
Yes, negative. So we're going to have, so with Broca's, it's going to be non-fluent. Is our comprehension intact? Because Wernicke's is intact. Good.
Oh, so you do.
Yeah, and then do repetition.
Okay, so okay, I get what you mean.
Okay, so this would be Wernicke's, right?
Yeah, okay.
Are we all cool? Or this would be Broca's.
Sorry.
Broca's, right?
I thought you were supposed to circle things.
No, you're fine. So we got global done. Okay, who wants to do Wernicke's? Let's go for it. So Wernicke's is going to be, let's do, is fluency intact?
Yes.
Okay.
Fluency, negative comprehension, negative repetition.
Good. Perfect. Done. All right. We want to do transcortical motor. Remember, transcortical motor is going to be in what part of the brain? Frontal lobe. It's closer to which area? Broca or Wernicke's? Broca. So it's going to mimic Broca but have something very specific.
Non-fluent.
Yeah, non-fluent.
So your comprehension is going to be intact.
Yeah.
And since it's just copying it, it'll be positive.
Yeah.
This is
Right, because
negative.
yes, transcortical motor. Perfect. And remember, because the Broca's and Wernicke's are still open for business, it's still going to conduct that repetition. Okay. Same deal, different story. Transcortical sensory is going to be more on the temporal lobe-ish, closer to Wernicke's, so it's going to mimic our Wernicke's. So if it's Wernicke's, is Wernicke's fluent? Yes. Is Wernicke going to comprehend? No. Is Wernicke, with the transcortical sensory, going to actually repeat?
Yeah.
Okay. So we're going to do transcortical sensory. Oh. Okay. And then what we didn't talk about is conduction. Conduction aphasia, what do you think that one is? What's that?
Only repetition.
Only repetition. It's basically if it's a deep injury into the arcuate fasciculus. So this one you'd be fluent, you'd comprehend, but your repetition is not gone. So this would be conduction. Cool. And then the transcortical mixed, which is
Just repetition is there.
what's that?
Yeah.
Just repetitions are right. Transcortical mix. Good. And then anomia is another one that's actually down here. Anomia just means, what do you think it means?
Can't even say.
Yeah, just no nouns you can't do. Boom. So you don't have to memorize it. You just have to remember so all I'm trying to tell you is just remember those concepts. I'll share this with you. So you can get those. On your rotation, it'll be like, this MTA struggling, what do you expect? Right? That's what I'm going to say. And then you're going to spit out a whole bunch of crap. You got to remember anything. You're like, they're going to be weak. This is what I did. I would have been like, they're going to be weak, and they're going to not speak, and they're going to need rehab. And then they're gonna be like, yeah, I think so. So let's look at it, right? Let's say it's a big MCA. You can have a superior and an inferior MCA stroke. Well, let's say it's a big MCA stroke, okay? So we have our central sulcus here, okay? So if you got an injury here, what's going to be affected? What am I drawing here? Sorry? Oh, can we start with the motor strip here? I'm sorry.
Oh.
Yeah, no, we'll get it. Yeah.
Sorry, I thought that was a neuro.
No, here, behind. Okay, what are you going to have?
Motor for upper extremity and
Face, right? Yeah. And then here as well, we're going to have the arm and face, but it's going to be sensory. It's going to be motor. Cool. We good? Yeah? Okay. Our Broca's area is going to be where? I think you had mentioned it.
At the closer to the frontal side.
Yeah, like right over here. So is Broca going to be messed up? Yeah, absolutely. And where's our Wernicke's? Is like right over here. Is Wernicke going to get messed up too?
Yes.
Okay. So which of those aphasias that we kind of brought up does this kind of fit the picture with a big MC stroke? Yeah, more of a bigger global. And there's a right-left discrimination part, but we're not getting there yet. And just from looking at the lobes, right? It's not, I mean, if there's one lobe that's really affected, it's not getting the core of the frontal lobe. It's got a little bit of it, but it's getting a lot of the temporal lobe and a lot of the parietal lobe here. So what do you feel like is going to be affected here?
Memory.
Yeah, memory is going to be a huge issue. And then what about proprioception, visual, spatial? You're going to see issues with neglect. There you go. That's MCA stroke. Now, if I were to cut this in half, that's how you just did. Like sometimes you'll see this inferior and superior division. We're just going to just based off the injury, you're going to see the different. You can look at the different. But if you just cut it in half, you can see if we had more of a superior division, you're going to see a lot of motor, but your memory is not going to be affected as much. And if you flip it, if you have an inferior division, you're going to have a lot more memory. Does that make sense? Okay. Let's say that we did an ACA stroke right here. Okay? This is where it is. Now we've got boom here. Okay. So what's here? This is sensory, this is motor, right? And what this is if this is a central sulcus somewhere around here, I probably left it out. Yeah, I did. Central sulcus. Let's say that actually central sulcus is here. Okay. All right. So we said motor and sensory. So what part of the body is going to be affected more with an ACA stroke? Lower extremities, right? So motor and sensory. Do we have a lot of parietal, temporal lobe kind of stuff? So it's like my memory going to be pretty, okay. It's still a big injury to the brain, don't get me wrong, but not as much. It should come back quickly. What about my Broca's, my Wernicke's? You're fine, right? There's one of the aphasias actually up here. Which one is that? Do you remember? What's that? It's not Broca's or Wernicke's, we know that. Transcortical motor. Does someone say that? Yes. So it's a transcortical motor. Is really up here. So what will you see? Will you see it's closer to Broca's area? So are we going to be fluent or non-fluent? Are we going to be able to comprehend? Yes. And then are we going to be able to repeat? Yes. So they're going to see some fluency issue, and that's the key. When you see some of the AC stroke and they're like, why can't they speak all that well? You can say it's a transcortical motor aphasia. It's going to be mimicking the Broca's aphasia. And then here's the key. What lobe is really kicking them? Frontal lobe. So what are they going to do? Punch in the face, right? They're going to be super disseminated, emotional ability, all that kind of stuff. So, that one done. And then what about your PCA stroke here? Are you going to see a lot of motor stuff with a PCA stroke? Not really from a pure motor strength problem. You might get a little bit of sensory, maybe. But what's your main issue with your? I'm sorry? Your vision, yeah. Your vision. The information, what you're seeing, is incorrect. So now the parietal lobe is interpreting, trying to collect incorrect information, but then sending it to the temporal lobe. And is your temporal lobe okay here? No. So the loop starts off bad and it ends bad. So what's going to be affected if you've lost your temporal lobe? Yeah, your memory. So this person is going to have some visual issues and going to have some big memory issues as well. They might have hallucinations. They might not realize that they have an injury, so which is a whole different kind of syndrome. And then what about language here? What do you think? Are any of the language centers affected? If you said Broca's, let's see, Broca's is kind of here-ish, Wernicke's around here-ish, transcortical sensory, transcortical motor, mix is like kind of all over there. What do you think?
What about naming? Would
What's
you
that?
get naming issues if
The anomia, I keep forgetting where that's located. But the memory part could be impaired. But just from a pure, like, are you going to get one of those language disorders? Probably not.
What you can notice, I just had someone who had a temporal lobe, not temporal, a parietal lobe tumor removed, and she was having a lot, what we could say, Broca's aphasia, and I think it's a lot of
Swelling. But during rehab, she's just, 1 week in, she's just making these huge gains, all because it was, a swelling issue and then anything else. So, and then just so you're aware, right, left brain function is important. When I talked everything about, it was skewed towards the left brain. So if this was a left MCA stroke, you would see all of that, just in terms of language and writing and all that kind of stuff. When you look at right brain function, it's all the. So if you look up the book tonight, we're going to show you like MCA stroke. If it's left MCA, you're going to see all those classic things we talked about. If it's right side, it can be different, and then it depends on your dominance. So anytime that you're seeing a stroke consult, you want to ask them, are you right hand dominant or left hand dominant? That's the reason why. Okay, so I wrote it from it just becomes so complex if you try to mix all of it together. So this is mainly your most common right hand dominant left brain injury, which is fairly common, is what you're going to see. Somewhat makes sense?